Thank you, and we'll keep questions to the end of the session. Now it's my pleasure to present Prof. Matti Aapro, the friend of our area. Professor Matti Aapro is the Executive Director of the International Society of Geriatric Oncology and President of Multinational Association of Supportive Care in Cancer. Prof. Aapro is going to talk about heterogeneity in HER2-positive population, cases of resistance, and future plans to overcome. Please, Dr. Matti.
Very good morning. Thank you, Sami, for your introduction. Dear colleagues chairing this session, dear colleagues attending this session, it's indeed a pleasure to be back. I still vividly remember the nice words of Professor Hesham last year, who nominated me a distinguished honorary Egyptian citizen, and I will continue to try to be at the level expected and interact with you, and it's going to be a very nice next 2 days of quite a few discussions with many of you in different settings. So I got this title, Heterogeneity, so-and-so, and I thought, well, thank you very much, Ahmad. Once again, is a challenge. And then I thought that I will have a solution to the challenge. The first is that I'm not the only one talking during the session, and many of us will have some ideas, and maybe we'll have time, even though we are running late at the end, to have some questions and exchanges about this. But I would like to attract your attention that the topic of HER2 positivity is going to be also discussed by several colleagues during these sessions. And you have here the titles, and I'm attracting your attention to these talks because they are within. And they will enlarge some of the points that I'm going to be making, and specifically the one on HER2 testing. And one of my last comments on the duration of treatment will be addressed in detail by Nurad Ibrahim a little bit later. So nowadays, there are many excellent meetings and excellent speakers at meetings, so I decided not to reinvent the wheel, because Karen Gelman very kindly gave to the whole faculty of ABC4 some of her slides, and she made a very good lecture, which basically is the one that Ahmad was expecting from me. And Giuseppe Curigliano at the ESO Arab Masterclass in Cyprus was going to give a talk about the situation in the clinic. Unfortunately, he fell ill, so he didn't give it, but he sent me his slides. And just last week, Professor Grigorov, sitting here and going to be the next speaker, also talked about this topic, and then I decided I had to give something original, so I came with overcoming financial resistance. So what is this all about? This is all about the fact that we know that the cells will be either from the beginning resistant to the action of an HER2 agent with or without a chemotherapeutic or other agent, or will develop such a resistance. And we know that there are many mechanisms that are going to be working there. And we also know now that we have clinical data that will remind you about that we do have ways of going to second and third line treatments with remarkable success, in the sense that we actually seem to be able to show that there is not only a response rate and not only a relapse-free survival benefit, but even an overall survival benefit at the end of everything we are doing. And all of this relates to the different mechanisms that are implied in this action, and I will detail them thanks to my colleagues with a few slides. It's a complex setting, and it's going to be detailed certainly very soon by my colleagues dealing with the diagnosis and pathology, because it's not as simple as we would have thought, and we are learning more and more that we have to be very specific on what are we calling HER2 positivity, and how we are determining HER2 positivity in order to determine which patients have the highest benefit. And one of the open questions today is, of course, and it was alluded to already because of the great interest that we have for the immunotherapy, as many people forget that, after all, trastuzumab is immunotherapy, it does elicit ADCC, that we have to take into account the tumor-infiltrating lymphocytes. There are zillions of mechanisms of proposed resistance. They are here on the slide that was prepared on the basis of a paper for Chen in 2008 by Karen Gelman. And I'm not going to be able to detail all of this for you, and it will be very tedious. But we have to understand that it's not simple. It is complex, and it will need lots of investigation. You will see very soon that there's a huge amount of evaluations of new potential active agents in the setting of patients that do have HER2 positivity. And we can see at this in another way as put forward on this particular slide, which is then simplified for you in a very simple wordings here. And as you can see, once again, there are many mechanisms. There are many mechanisms of resistance, and we have very many different ways of overcoming, if possible, this resistance. And I will allude to some of these drugs which are under development, showing to you that some of them are promising, others are not, some are very early, and I will not be able to go through everything anyway. So obviously one that excited everyone quite a few years ago was when Sunil Verma and colleagues showed to us, and was then published in the New England Journal of Medicine, how TDM1, which combines an anti-HER2 agent and a cytotoxic agent, maytansine, in the same molecule, was able to elicit responses in patients who had been progressing previously on trastuzumab and other agents. We tried then to define who would be benefiting a little bit more. Could we define which mechanism was going on in the cells that would define which type of treatment would be needed? And we had some hope that the PIK3CA pathway would give us a signal. And as you can see from the data from the Emilia and the Teresa trials, no, we didn't get a signal there. Whereas with another type of approach, in these types of patients with everolimus, we do seem to get a signal that yes, indeed, patients that have PIK3CA mutations and PTEN low are patients that are going to be possibly have more benefit from this type of approach, published by Fabrice André in JCO 2016. So, one of the questions that Karen alluded to, and which was part of the title that was given to me by Ahmad, was, is this because we are not actually addressing the specific population? Is this because we are actually relying on the data from the original tumor and not addressing the metastatic setting? And as you certainly know, there are some conflicting studies saying, yes, it would be important, but we don't really have definitive data to say that what we elicit in the metastatic setting is really significant. And we have lots of hopes for new methods that look at the circulating tumor cells, but that is beyond my talk at this point in time. So trying to say just that we have to be really looking at those tumors that are indeed expressing in a specific way the HER2 receptor, which is determining their response. Here's some interpretations that Karen shared with us on the NEO-ALTO and Karen's study showing that the HER2 enriched cells are the ones that are going to be responding to these types of treatments. Then one question which is open, and there will be a session actually about brain metastasis, is when the patients have brain metastasis, do they actually respond to manipulations around the HER2 pathway? People saying, oh, these antibodies will not get into the tumor. And we do have data that actually, yes, they do get into the tumor. And we have clinical experience that some of the agents will have some activity in that particular setting, including also the TKI inhibitor tucatinib. So this was taken by the panel of the ABC4 meeting, and this is one of the slides that Fatima Cardozo asked us not to show before the publication is out, but I know that the whole world of all my colleagues is showing them, so I'm showing them too. And basically we discussed again, and we said that, well, we need clinical studies because everyone has this little bit of information that these patients might or might not be responding in these settings to manipulations outside of the tumor area. and this was what was voted upon. But as you can see, the level of evidence and the grade of the recommendation is not very good, in the sense that we do not have a lot to say in this setting. We need the studies. And you can also read the previous statements for your information, reminding you that the standard today is to restart. And I know that in many countries, when the patient has been often anti-HER2, it's difficult to restart, but that is the recommendation in the setting of the patient that unfortunately have a brain progression. So from the conclusions of Karen Gelman, this is what I can share with you. We are not doing a very good job. We are launching lots of studies with lots of agents, but not really able to define what is the reason why the tumor is progressing. And this is one of the big problems that we have today and we will have in the future in all settings, in breast cancer and other cancers, that we have to understand what is the actual biology that is behind what we see from the clinical perspective. So where are we? I could have started actually by this, but it's just a very short reminder to you from what Giuseppe said, was going to say at the Cyprus meeting. The message overall is here. We have done a lot of progress in this setting. There are always the nihilists out there that say, yeah, well, you give this and you give that, but at the end it doesn't make a big difference. Well, at least in this setting, there's certainty that by giving the treatments, and I'll show you another slide a little bit later, and continuing to target the specific pathway in these cells, we now have enough evidence that the consecutive treatments will make a difference for your patients. We know that we can be effective in second line in terms of survival data. We can be effective in third line, even comparing to what the clinicians would like to do, because clinicians always think that they know better. Well, they don't really know better, because when you do have an active agent like TDM1, whatever your choice is not going to be as good as an active agent. And of course, I have to allude to, but this will be discussed in detail at this meeting, to the Panacea trial that has shown that indeed in HER2 positive patients, there is some that will respond remarkably to immuno-oncology as defined today. Open questions remain, as put here forward by Giuseppe, and again he addresses the brain disease, we have issues in the bone disease, chest wall disease, and in the ER positive ones, we are now starting to look at data with the role of CDK4/6 in these particular patients when they are HER2 positives also. So then you are very frustrated because I didn't tell you anything about these wonderful new drugs. I just alluded to tucatinib very quickly just a few seconds ago. And I was trying to think, oh, I have to prepare a few slides, and then I was so happy to see Joseph Bigorov giving his talk last week, and he kindly sent me his slides. So I could sleep one more night instead of preparing slides for you. So thank you very much, Joseph. And once again, one of the key messages, yes, there are patients that are going to go through the treatment, progress, but we can continue to keep the pressure on. And as we keep the pressure on, I'm certain that Jose Cortez in his lecture tomorrow will be showing once again this slide. This is what is the reality. We are pushing the frontier of the death of the patient more and more far out. And this we have to keep in our minds. This is not like in other cancers where we do a little bit of cosmetic treatment and regrettably the patient dies. So there are the TKIs, and there are several of them. Tucatinib I alluded to. It has some interesting data. I'm not going to detail that to you. I'll just show to you that, and I will not detail afatinib, which seems not to be very promising in this setting, at least from the data available. But with neratinib, we have some interesting data, and the first one is from Skip Bernstein's a paper a few years ago, already 7 years ago, that showed, yes, it has some activity in these patients. But then we have another paper that is the one led by Miguel Martin that said, well, it has, compared to lapatinib and capecitabine, a little bit of activity, but it's not really that good. And then finally, we have another paper that here saying that neratinib plus paclitaxel versus trastuzumab paclitaxel actually doesn't make much of a difference. So then we have the monoclonal antibodies, and there are several of them here, and I will show you some data about them. Here's about margetuximab. It does show, yes, some activity. We have the phase 1 data. It is ongoing for further evaluations, if I understand. We have MM111. Once again, there are signals of activity in this particular agent. We have ertuximab, which is a very interesting one, which works on a slightly different, more defined pathway than trastuzumab. And we do have some phase 1 data to show that, yes, it is active and it is going to go forward. And then we have another interesting agent, a concurrent to TDM1, which combines a cytotoxic agent with an anti-HER2 agent that has shown also in LaRusso's study some interesting data and is ongoing for further evaluation, as you can see on this slide. Of course, immunomodulation is going to be one of the topics of this session, of this meeting. I'm not going to be detailed anything there. I just alluded to some interesting data. And Miguel Martin made a very, very nice review at ASCO 2016. And here's a reference to some of the vaccines that are ongoing. And we have a lot more. If you go to, as Joseph did, to the nci.gov website for clinical trials, you have many, many companies fighting there for patients, for good data in order to hopefully give us more promising agents that will keep the promise as they go from phase 1 through phase 2, through phase 3. This is slide number 1, and this is slide number 2. And I have only 4 minutes left. And I thought I would have some questions. I planned 20 minutes minus 3. So the final point that I would really like to share with you, and Ahmed and Hesham, I think we will have to have a discussion about this at the next meeting, is that the whole world is facing the issue, which in some ways is wrong, of saying that because of the cost of our drugs, we are not going to be able to treat our patients anymore. Just a point. In Europe, the cost of drugs in oncology compared to the overall cost of treatment of a cancer patient represents, worse for the worse, 1/5 of the cost of the treatment. Even in some cases, much less than that. And overall, in Europe again, I don't know the figures in your countries, the cost of treating cancer represents half of the impact in terms of deaths related to cancer. So the governments cannot be saying that we have to decrease the budget for cancer treatment. We are underfunded, at least in Europe, dramatically underfunded. And it's not for drugs, it's for care of our patients, compared to the impact on patient survival and the impact of early death on the society. One of the points in many countries is that, regrettably, these drugs have to be paid by the patient. And there has been a debate, and it's an ongoing debate, and we have just recently data from the Finnish study sold by Heikki Joensuu at San Antonio, telling us that, yes, a full year of trastuzumab is better than a little bit less, and a little bit less is here considerably less, as it is only 9 weeks. So if I was the health minister of a country and I, for some strange reason, said I have to limit the use of trastuzumab, I would open it for every single patient in the adjuvant setting for 3 months, saying that maybe I cannot, and I have to deal with, regrettably, a little bit more deaths, but at least I would be saving the lives of many more patients. And if you look at the other studies, they all point that the difference is there in favor, not always statistically significant, of longer use, not beyond 1 year, but not in favor of not using at all, which happens in many countries. Final words, biosimilars. These are data from the introduction of biosimilars in the GI area. Has nothing to do with cancer, but we do hope that this is what's going to happen all over the world now that we have biosimilars in anti-cancer treatments, not only in supportive care. Dramatic drops in costs in those countries that have been able to deal with the companies. The European Society of Medical Oncology has a position paper on biosimilars. I invite you. This is open access. This is a very well thought of paper. And at ABC4, what we indicated is that if you are approached by a company selling you a so-called biosimilar, just check that this is a biosimilar that has been approved by EMA or by FDA. With that, with the song here, or the gling there, I would like to invite you to send your juniors to the masterclass that they will be going to have at December 2018, most probably once again in Cyprus. And of course, please come 2019 to the ABC5 meeting. Thank you very much for your attention.